Kia ora, Bulavanaka, good morning. Firstly, I think I must say I appreciate the opportunity to present at this forum. And it's actually my first time I'm presenting in New Zealand. Done this quite frequently in other places, but it's a privilege and honor to be here. And basically, I work with the Ministry of Health and Medical Services, and yeah, you must be thinking, talking about Fiji in a New Zealand conference, we're your neighbors, we're not too far. I got into a flight, it was just for about 2.5 hours, 3 hours away. So we're very close. Obviously, we always share the brother and sister relationship in this region. And we just heard about the funding cuts. Fortunately, Fiji is not affected in that context from the US PEPFAR context, but I'll talk about it as we progress in terms of what's happening in Fiji. So I hope I get this right. Okay. So yeah, well, I think I'm presuming a lot of us have been to Fiji. We're just neighbors. I'm presuming that. I sat beside somebody who was just gotten into Auckland from Fiji just yesterday. So yeah. So I don't think so. I need to talk much about it, apart from the fact that obviously we've got 300 islands, more than 300 islands in the nation, and 2 major islands, Vanuatu, Viti. A fifth, almost a fifth, bit less than that of your population. Last census in 2017 was 884, 887, with about 212 health facilities across the nation. And I've always admired, I must say, the Fijian health structure, but obviously there's a lot of work that needs to happen within the health system. There's a difference in that. And talking about HIV, it's something that I've worked in for the past 15 years, and with obviously gaps, but it's a scenario I saw some 15 years ago, which unfortunately I'm seeing reality of it today. And when you look at it, I'm not sure how closely you follow Fijian news, but if you do, our first HIV case in Fiji started in the year 1989. That's better. I can see you better. Sorry, I'm short. I was wondering if it could do that, but yeah, it did. So yeah, so in 1989, does this have a pointer? Yes, no, no. Anyway, so 1989 was when we had our first case in Fiji. And I must say, glad to say that that person is still living and well today, has grandchildren, etc. So that's a proud moment to say, yes, but progressively over the years, we've been increasing cases every year. And in the most recent years, as you can see, in 2024, we had a total of 1,583 individuals who were diagnosed with HIV. Now, in 2023, we had 415, and you might question what happened during this one-year period. And we all know, I believe I'm not talking to any person who does not know HIV or this space. You test more, you get to see more, right? And one of the biggest challenges that Fiji faced was increasing our testing capacity. And why did we face that? Obviously, in the Pacific region, and maybe New Zealand might face the same, but I guess you have a lot more access in terms of funding, context and better communications across the world with production. So we basically, when we talk about this, obviously, our purchasing power is very small. When we talk about less than 1 million people, and say, for example, even if you want to test half of that population, nobody would want to sell you testing kits at a very reasonable price. So purchasing power in the Pacific is always a challenge. Anyway, having said that, a prevalence of about 0.43 from comparing it to the census data in 2017, an incidence of about 178 per 100,000 population. And when we compare it to 2023, we had 415 individuals who we diagnosed. And when you look at it, 281% increase from the 2023 data. Total cumulative, we've got people living with HIV in Fiji is about 3,660, but this is just, I feel it's still just the tip of the iceberg, because obviously the more we go out and do more testings, the picture changes as a whole. But having said that, I believe there's a number of clinicians in this room as well. And when I did a presentation in Australia last year, is where actually I met Mark and the team, and he had approached me. We talked a bit, and some of the clinicians told me, you know what? I see a lot of HIV patients or Fijians in Australia. I'm not sure if you see that here, and they were presenting with AIDS-like illnesses in that stage. And these were obviously through different platforms, forums that you'd go, either migration or through the scheme that's working, the work scheme that happens between the region. So that was something that was trickling over to that's happening to Australia and New Zealand. And when I talk about Fiji, I just want to be pretty clear that what's happening in Fiji has a ripple effect in the Pacific, in the region as a whole. And we're seeing that already, and we are likely to see, because in the Pacific region, it'll be a good question to ask, how much testing do we do as a region? How much testing do we literally do? Anyway, having said that, just the numbers across 2018 to 24, you can literally see the jump. We literally scaled up a number of testing, but still it was not enough. It's still not enough. We need to ramp this up. I'll share what programs, etc. we've done a bit later, but in 2024, we literally rolled out point-of-care testings and did a number of other things. So total diagnosed, like I said, 1583 total people living with HIV, excluding the deaths, unfortunately, we reported was 1523, and enrolled in care, unfortunately. Honestly, it hurts me when I say this, but enrolled in care was only 50.6%. They're people who would not come back for their test results, or we'd lose them to stigma discrimination, and a number of things. There's a number of scenarios that goes behind. And of these on ART, on medications, is 711, and those not enrolled, 753. And reported deaths, unfortunately, last year, in 2024 alone, was 126 individuals. And, you know, in this era, one death is just too many in this era. We literally cannot afford to see any deaths, but obviously we've seen deaths in this space. There's various reasons. Obviously, one of the major ones is stigma discrimination, neglect from family, and to the point of fear that HIV is a death sentence. But there's some advocacy context we want to talk about. So if you've been to Fiji, you'd know the city. You probably end up in Nandi side a lot more, the Western Division, where you literally land in the country. We had about 427 individuals who were diagnosed there. In the Central Division, about 1,100. This is the Suva city, the capital of the nation. And if you've been to the beautiful islands in the eastern, which is also challenging, we have no place in the country is exempted of a case. No country, no town. I wouldn't say village will be probably too narrowing down, but no area per se is exempted of a case. Every place in Fiji, every particular area would have, every town or every particular region would have a case or so, or a few at least. So yeah, and one of the largest things that's happening is the shift. We're shifting more towards the younger population now. I'll show a slide later, but the shift is literally towards the adolescent health age group. Now, less than 40 for sure, but when you look at the even under 29, under 30 years, there's a significant number of, and this is basically the prime of the nation. Literally the economy depends around this population for tomorrow. So when you see that shift, I just wanted to, So within the prisoner screening, just within that population, we had about 8% in 2024 alone. And these were individuals who were in remand or in prison. And I'll share the modes of transmission very soon, but predominantly injectable drug use as well. But yeah, prisoner screening, this happened through point of care, through our prison team's collaboration. So we did a number of screenings through our NGO partners. So the Ministry of Health collaborates significantly with our NGO partners, and one of them is medical services specific. Our Global Fund grant, about 70% of it, rather than it coming to the ministry, 100%, we gave about 70% to an NGO because they become our hands and our feet on the ground. Already we're limited with resources. Unfortunately, a good number of doctors and nurses migrate to Australia and New Zealand, and COVID it did not do good to us as well. We lost a lot of healthcare workers through this process. Now, when we look at sex workers, screening with sex workers, 17% just within the sex worker population, again through that point of care modality. And we did a number of programs around this space as well. But 17% in comparison to about less than 1% in 2012 when we did the integrated biological behavioral survey is quite significant. when you see it in just over more than a decade now. Now, when you look at trends, age group, I just put this slide in here for just a comparison in terms of seeing what happened over 22, 23, 24. And when you look at the 15 to 19, from 6 to 30 to 165, sorry. And when you look at even 20, 24, 25, 28 years of age, literally increasing significantly. And we did have mother-to-child transmission. Unfortunately, it increased. In 2024, we had 31 individuals, children who were born due to mother-to-child transmission. And that is a reality. But there is opportunities in this as well. Because for us in Fiji, we have almost 99.9% of our women who go through a health facility delivery, literally. So there is opportunities. Only thing, like I mentioned earlier, we need to strengthen the systems, the processes that's in place. When you talk about gender, predominantly male, 70% male compared to about 30% females, and transgender about 7%. Now, this dynamic has been a changing, shifting dynamics over the past few years. Now, why I say that? Now, when you look at this particular graph, you look at it from initially, predominantly in the very early days, we had almost a 50% male and female ratio. It's just been over the last 3-4 years we're seeing that shift. If you can see that upward curve within the male and the downward within the female. Now, I do need to do one thing, is I need to look into the number of males and females I'm testing firstly on the ground, obviously to validate this. But when we're looking at that, is it a behavior change? That's something that's unknown. We do have a number of, there's MSM, transgender, there's also bisexual, like who would deny it. So there is a shift in terms of the number of cases when we talk about HIV in the male and female population. So when you talk about ethnicity, where do we see it more? This again needs to be validated in the sense, who am I testing more? Am I testing more Itoke population compared to Fijians of Indian descent? So, but 90.3% is seen within the Itoke population in comparison to Fijians of Indian descent. Sometimes I feel the Fijians of Indian descent in Fiji are too naive to get tested. They think they know. Sometimes we would like to say that sometimes we think we know it all and I'm not at risk or something, but sometimes it's good to just get out of the box and just get a test done. So those are some realities on the ground we need to sort out. So programs even targeting Fijians of Indian descent to make sure we increase our testings. But yeah, when you look at it as is, when you look at ART, I talked about basically the cascade on ART. This is total in number ever since 1989. 1583 individuals who are on medications. And about 44.9% on treatment, 3.7% not, and not enrolled in care, 47.3%. But now mode of transmission, when we talk about mode of transmission, of the 1583 individuals, mode of transmission was known among 701 individuals, 701. So out of them, we had about injectable drug use, which is 48%. Of the those known of mode of transmission, or 21% of the total new cases in 2024 alone. So sexual transmission was second to that at about 47.4% of those known with mode of transmission, or 20.9%. So sexual and injectable drug use is something that's predominant, and obviously mother-to-transmission, child transmission is 32 with 4.5%. Now, when you talk about IDU, this was never the case in this nation, in Fiji, for us. We never used to see IDU cases till most recently. It's either people denied it. We do know there has been drug issues. If you Google Fiji right now, you'd be probably hearing the largest drug bust in the region of about 4.5 ton drugs found in Fiji. They're going through the court cases right now with news saying there's political involvement, etc. in it. But having said that, injectable drug use is a scenario in the nation which is concerning. And needle syringe programs is something that we've been talking about most recently in the last year or so, a bit more than a year. Previously, if we had it'd be just 1 or 2 cases. 2023, we had about 24 early in the first half, about 17%. Now we're looking at close to 50% of the known transmissions, or about 21% of the total. So this is an urgent need in terms of what needs to happen on the ground. Yeah. So this is by the breakdown of the divisions of this nation. We have 4 divisions in the country. Sorry, I forgot to mention that. We've got central, western, northern, eastern. Central and western, northern are more, urban, peri-urban, obviously with highlands, but eastern is predominantly maritime. So that's a challenge in itself. But having said that, when you're confined to a place and you provide point-of-care testing, it's not that, you're not too confined again. So we've got some modalities going on in terms of reaching out there. And interestingly, prior to 2023, last quarter around October, November-ish, we predominantly screened individuals through our laboratory-based systems. We withdrew blood, we sent them to the hospitals, got results, and this was one of the huge contributing factor to delayed treatment starting, etc. But in around 23 and where numbers literally started to escalate is what we're seeing, we introduced something, we introduced point-of-care testing. But having said that, that point-of-care testing was not confirmation. We didn't confirm on site, but at least we did screening on site. So we did screening for HIV, syphilis, duo, and also hepatitis B. So that we introduced gradually in our 3 sexual reproductive health clinics. And having said that, last year alone, the point-of-care testing gave us a 5% positivity rate in comparison to the total testings we did. And in total, we did about 60 around 70, close to 71,500, out of which 90.9% were lab-based testings confirmation, followed by the positivity with the point of care. So we know point of care works in this nation, and we need to literally go out to get more testings done through point of care rather than having individuals wait. And we are now moving towards point of care confirmation as well. We're gradually getting there, where we could literally test them and initiate treatment immediately. And so unfortunately, the deaths in the nation have gradually been increasing. I'm not sure if we could blame COVID for this, but I don't think so. We should blame COVID for everything. It's not fair. But, COVID did a lot of good as well. It brought it just brought in spaces which allowed us to work with and build up systems, strengthen systems. But no, like I mentioned, deaths is something that, in Fiji that has various reasons. Either people would not turn up to health facilities on time to get tested. They were in very late stages with opportunistic infections, or probably naive to treatment, which does happen. And some even revert to traditional medicine, which is also common in Fiji. Probably in other places as well, but common in Fiji. And sometimes if it's even healthcare workers, what's your capacity to even recognize HIV? We've had patients who've walked through our health facility several times, but unfortunately never tested once for HIV. It has happened, not that it didn't. So building capacity, before I came back into the ministry some few years back, there was no HIV training for healthcare workers for almost 4 or 5 years. So you can imagine the capacity in itself to recognize what's not there. Obviously, you don't see, you don't do. That's a basic principle. And the more exposure you get, the more experience, like you build up that experience. And that's something that we've seen. And now we definitely test, with the testing increases in the hospitals and across the country, this is really helping us in terms of diagnosis. But we need to reduce our deaths, and obviously advocacy and a number of things need to happen. Number of people in HIV total, I think I'll skip this one. Viral suppression, it used to be very centralized in the nation. And when we gradually got a lab personnel to sit in HQ with us, we managed to decentralize a number of things. These numbers are still not good, in my opinion, not good at all. But this is something that we're working towards with the decentralized testing for viral loads. So with the decentralized modality, we're definitely increasing our viral load testing. But in total, 244 individuals are virally suppressed. It's a gain, it's a win. These are small wins, but there's opportunities for larger wins in this space. And with the more decentralized work that we do, we will definitely get there soon. Now, when I talk about programs, I'm just going to briefly try and touch, because I know I'm also mindful of time. Our national HIV response, one of our biggest wins over the past few years has been government commitment. I'll be honest, we've never got a donor funding to pay for medications in Fiji. So it's predominantly government funding from the time we had medications in the nation. And most recently, Global Fund asked me, would you like medications to be brought out of Global Fund? I said, no, keep the system as is. Let the government continue to pay for it. Why have a donor partner come in and pay for medications when already the government's supporting it and they continue to support it? So building up on those opportunities. The government commitment has been our biggest win. And most recently, we developed our National HIV Search Plan. We've done divisional analysis reviews. We've also we declared an outbreak earlier this year in January, end of January, and we've got now a new SRH HIV unit. We've got, condom campaigns. And one of the things about condoms is people always say, I don't want to use condoms. But that was something, but the other thing was it accessible to individuals who needed it? Some would pay for it, some wouldn't. Some wouldn't walk up to a pharmacy. It wasn't accessible in every single site you go to. So one of the things we did is with the UNFPA, we developed a condom campaign and we deployed about close to 165 condom dispensers across in the Central Division. We did it in pubs, hotels, short-time motels, public restrooms, universities, vocational schools, and trust me, the usage went up. The usage went up, and we're just evaluating that program, and with that, we're scaling up. Because the thing is, if you walk into a public toilet and just walk out, nobody knows you've picked up a condom. And we realized that in pubs, etc., the condoms would finish in a day. Overnight, it's gone. People would have to refill. So there is a demand. We need to meet it and obviously support individuals on how to use it as well and make sure, we don't know if people are using it. You can't assess that. That's another behavioral context we need to study. But having said that, if people are accessing it, they should be using it, right? They wouldn't go out and sell it. They would maybe, but even if they're selling it, someone else is using it. The cycle goes on. So yeah, and obviously, like I mentioned, point-of-care testing. We literally do point-of-care testing any opportunity we get. If you follow the games, is it Super League, where Fiji and Drew are games, and you've got some of your teams come over. We even have testings on site there as well, on the ground. So we do every opportunity we take, we go out and test. We've even done it in men's and mixes games, tournaments of netball, etc., safe campaigns. Moonlight program was for our sex workers in Fiji and street dwellers. And we've got some research going on as well, some rapid, we did a rapid assessment for people who use drugs with a focus of people who inject drugs in Fiji. We've got results, which I'm not presenting today, but we will release that soon, so you can definitely access that online. But we are doing an integrated biological behavioral study for drug use in Fiji as well. Because this is, if you honestly Google right now, drugs in the Pacific, including Fiji, you'll be surprised. There was a narco submarine in Solomons just a few days ago. So it'll be interesting for you to see what level of drug cartel is happening in this region to supply no one else but New Zealand and Australia. It's interesting to see how that's happening. And we're doing an integrated biological behavioral study for key pops as well. And we've got some CSO grants going. Basically condoms, like I mentioned, we're strengthening capacity for healthcare workers, strengthening the partnership with our civil society organizations, target massive screening roadshows across the nation, building up on that. We're using our safe campaigns like hibiscus festivals, our carnivals around the country, using the Moonlight campaign, basically upping our screenings on the ground in all modalities. And there's also opportunities for us to be exploring the self-test kits as well, because there is a certain group of people who would not turn up to health facilities, or what more can we do for them? Oops. Did I go too fast? Yeah. And we've got this, we're decentralizing our modality of test and treat out in the field now. Rather than having it at the sexual reproductive health clinics, we're trying to move it out to every single medical area, as in every single town. We're trying to up their capacity in terms of having treatment available on site and capacity building as well. One of our largest challenges was the information system. And the information system is what we're trying to set up. Because without that, without information, there is no program, right? I mean, it helps you. Thank you so much. There's a sign, I need to stop talking soon. So, yeah, we're decentralizing our services and training capacity, but having said that, our information system is something we're building up on. Australia is helping us build this up with something called Tamanu through Beyond Essential. And we're rolling this out in the very near future because we want real-time data. You'll notice that I did not present 2025 data. It's August already. It's difficult when your numbers are so huge. Validation is important. I can't just present any number. I've got to validate it right. And if you've got like 19, 20 Excels to consolidate and verify that they're not old cases as well included in there, it takes a bit of a time, especially with limited HR as well. So yeah, setting up an information system for us is absolutely essential. Like I mentioned earlier, we decentralized viral load and we also decentralized early infant diagnosis. We're doing some laboratory strengthening as well for point of care rollouts. We're also validating right now our CD4 point of care testing with availability from UNDP. Absolutely essential for us in all of this process. If you're a lab person here, without quality assurance, you can't go forward. And you wouldn't encourage anyone to go forward regardless. And obviously procurement, recruitment of lab staffs for the clinics. Like I mentioned in the beginning, government ownership has been a big win for us. It's been a win. And this year, August is our new financial year, so government committed 10 million Fijian dollars. Alongside, thank you MFET, thank you New Zealand, this is your taxpayers' money. You've got 4 million contributed to us for the fight of HIV. And if you're an Australian, your taxpayers' money of 3.7 million AUD. And it doesn't stop there. There's been other supports as well. But with the new SRH HIV unit in the ministry, it's been good and more focused and a lot more human resources going in there. But honestly, without the government commitment and ownership, I think it wouldn't be a way forward for us. Challenges will stay that we really need. I literally put my hand up when I said, when we saw drug use come up last year, I was like, look, I don't have technical capacity, I need help. Immediately last year when we were seeing this. Why? Because none of us have dealt with it in the Pacific. We don't, but it's there. I think I talked about the digital system, but it's work in progress. But I'd still put it as a challenge there because, like I say, data speaks volume. No data, no program, no work forward. I mean, what happened? DFET supported us in 2023 to procure kits to help us roll out point of care. With that 150,000 investment. That time, we had the 1,500 cases we saw. So you can imagine what that small amount of injection of money into right resourcing can make an impact on the ground. So, yeah, I'll leave it at that. But thank you for the opportunity to share today. It's been a pleasure. Don't bombard me with a whole bunch of questions, please.
Sorry, me again. I work in the drugs and alcohol service. Methamphetamine is my biggest nightmare. There's no treatment. There's basically, we have never seen the influx of meth that we have seen before. It's obviously coming from there, and from the gangs are very well established. Unlike opioid use disorder, we can treat it, we can give it, we can stop people on methadone and buprenorphine, nothing with methadone. But one of the things that have make a change here and reduce harm is needle exchange. And I just wonder where is the country and what is the government position about this? Needle exchange.
Needle syringe, okay. Oh yeah, I didn't mention it there, my apologies. Needle syringe program is something that's in progress. We're working on that, and we've got government buy-in and opportunity to support that. Currently, we've got some Australian agencies that are helping us work on that. But honestly speaking, more hands on deck would make a difference, especially with the knowledge. Like one of the things, I had a meeting yesterday with the New Zealand Drug Foundation, and it was really amazing to see that you've got Pacific people in this country leading who are drug users who've come out of it. And honestly, to make that difference, you need a Pacific Islander to go into the country to make that difference and speak to the people of the nation. So I think those important collaborations are essential. So needle syringe program is in the cards. It's happening in the very near future. The intention is before the end of the year, we do want to work towards that and make sure it's available. If you, honestly speaking, if you go and just Google Bluetoothing injectable drug use or something in Fiji, you'll see viral videos of kids sharing needles. Kids sharing needles. And when the report comes out of the rapid assessment we did, it's amazing, it's saddening to see that they're literally using blunt needles over and over and over again. And but having said that, there's another win that's been there, which I forgot to mention here, was we've got, apart from the surge strategy for HIV, we've got a narcotics strategic plan that's been implementing now, which is looking at supply, demand, and harm reduction. Right. So that is there. So I believe it's all available online, both the documents. It's a good read, but one of the good reads also is the rapid assessment which has come out. It's definitely, it's out there, it's happening, and honestly, the youngest I think with IDA we've seen is probably a 10-year-old, unfortunately. Unfortunately, young people out there.
Kia ora and Bulla, thank you so much for that amazing talk, Rachel. My name is Emma, I'm a paediatrician. I'm interested in your antenatal testing and also that your comment around the incredibly high likelihood of birthing in a health centre. What does that look like? Do you mean a health centre that can access intravenous caesarean section, or do you mean supported doula-type maternal care? Thanks.
So basically, with our policy in Fiji is all ANC mums will get a HIV, syphilis, and hepatitis B screening. That's for sure. Obviously, they can decline it as well. It's opt-out there. But one of the laws that we haven't used so strongly is our HIV Act gives that right to that child. An unborn child has a right in this context. We haven't strongly used it, but there's opportunities there. But having said that, at the health facilities, when I say 99.9% turn up to health facilities for delivery, it's not C-section, literally at the health facilities on the ground. It's all at the tertiary or at the subdivisional level. For example, what I mean by subdivisional or sub-district is basically, if you enter Nandi is a town, that area has a hospital. And if you enter into Nosuri, Suva airport, that area is a town. So they have a maternity unit. So they would be able to deliver as well. For C-sections, they would refer them to a tertiary hospital, which we've got 3 in the country. In the northern division, on the other main island, second main island, Vanuatu, and 2 in Vitilevu, which is the 2 main islands. But there's definitely opportunities. And one of the things we've done recently with maternal health care is maternal child health policy has been endorsed, and we're implementing it, where basically there's been always a linkage break in Fiji for services. For example, if I'm in maternity unit and I'm HIV positive, I lose you the moment I go into the health facility because there is no linkage in terms of service. So we've made that change where literally now we're looking at mother and children equally rather than just the child. That MCH lost the maternal aspect of it. So that policy is coming about, and we're making that linkage to make sure if you're HIV positive, you literally follow through. Or if you're never got your results for some reason, I'll make sure that you get it at the MCH clinic. And we've got about more than 95% vaccination rates in Fiji, so they do turn up. So there are opportunities as well in this context.
Kia ora, I'm Benji here. Does Fiji have like a consent program when it's discussing about sexuality and like consents around sex in high schools and stuff, especially around consent around condoms and stuff like that? And the second part of my question, because it's a 2-part question, does Fiji think of, is there any thinking about possibly funding female condoms as well as the male condoms? Because, you know, men are mostly the ones that like don't want to wear the condoms. So they're a bit arseholes. But also female condoms are more easier to have that conversation around, like, well, I've got a condom in me, so.
So in a nutshell, I'll answer your second question first. So our dispensers have 3 things: male condom, female condom, and a lubricant. So we've got all 3. So, and we've seen all three go, literally. Now, in terms of consent, our consensual, like our consent for sexual intercourse is, I think, 16 above. Marriage is 18. And even access to condoms. Our HIV Act is quite strong. So if a 10-year-old walks up to me, and I don't know that that person is 10-year-old, but in my opinion, as a healthcare worker, this child that's a 10-year-old walks up to me and talks to me, and I find that person matured enough to make a wise decision, appropriate decision. If I do not provide a service to them, if they ask me for condoms, I'm liable to be imprisonment or something, or being fined. So our law allows preventative measures to be given, such as that, to our kids as well. As long as, in the opinion of the healthcare worker, that they sound enough to make a decision. So yeah, even children in this context are pretty well supported.
Yandra Vinaka, Kaise, Vasu, Korotongo Village. And I just we got 4 questions actually. One question, I mean, I've been to Fiji myself and even gone to my village and done health promotion there with the men around condom and safe sex, because we have a high, pregnancy rate happening there. And it's quite complex because it's quite religious. And then access to condoms is quite complex too. And if you have a health district nurse that comes from the village, there's no really even privacy, especially if you're drinking around the Yangona bowl. But the other thing I wanted to say is, what is the government's responsibility, or what going to be around harm reduction? Because I've been to in the Nandronga region where they've had the police commissioner come there and take a real criminalisation approach to drugs being harmful. And I'm also a peer lived experienced sex worker and person who's used drugs, and I work at a needle exchange program here in Aotearoa, New Zealand, work for New Zealand Sex Workers Collective for 25 years, and strong advocate around sex worker rights and harm reduction with our key population. So what sort of things are going to be done there with the Fijian government, and if there's anything for us here to add any technical support or lived experience support as itoke, I'm happy to put my hand up with many other people in the field who work in the sector. And also another question here from my sister.
That's putting me on the spot. Kia ora, my name is Judith. I don't know if it is a question, but I work for Positive Women, and we do supply the condom, female condom and the male condom. And for us, we have seen many Fijian women holding the female condoms. And my question is your government probably investing in the female condoms? Because we know male condoms are free, but female condoms are very expensive. Even here in New Zealand, is still not funded. But I have seen people from different countries, especially the country where the culture is very strong. The women have the power to negotiate the sex, and therefore they will need that female condoms. Do you know then if your government is willing to fund that female condom for your people?
Thanks. I'll answer those few questions. So yes, we do have female condoms, like I mentioned earlier, and we give them out publicly through our dispensers. But having said that, when it comes to condoms, I just wanted to say one thing. Just to make it a bit more attractive, I've actually asked for flavored condoms, so it spices things up for people. So so they have to be innovative, right? I mean, the reality on the ground is innovation. So I think we work very closely with UNFPA and UNDP on this one. And that's given us opportunities to build up this condom campaign. And it started off, we knew it would pick up, but we just needed to hit the ground running, saying like it's available usage. In terms of your community context, now one of the things we're working with the community is, firstly, we are working with the provincial council team. For us, if you know, in Fiji, just like New Zealand, your cultural system is so strong and well, supported and well acknowledged. In Fiji, our provincial processes are very well supported and acknowledged. And I believe it's one of the amazing structures in Fiji to work with is our provincial council team. That's the Itoke through the through that ministry. So we're working through them, and we're trying to be innovative in where we place these dispensers. We haven't reached every single site of the nation, but we intend to reach every single site, whether it be, for example, within the health facilities. Usually condoms are left inside right now, and they're predominantly for family planning. We're trying to change that behavior, that let's put it in, every health facility has a toilet, a private toilet. Like let's put dispensers out in toilets where kids could just walk up and grab something, or another conducive place like a village hall or something. But we're working with the Itoke ministry. And now when we talk about harm reduction context and the police being quite like demeaning in terms of the legal side of things, we're working with them on this one. And it's very accepted, like, okay, harm reduction programs need to be acknowledged, and it will be acknowledged. And when you come to, when we come to the implementation of the program, honestly, when we initially started talking about drugs and needle syringe programs, one of the immediate response for police was, and you'll probably see it in the news papers as well, is police patrolling pharmacies and saying you cannot sell needles, syringes to anyone unless they have a script or something. And the pharmacies changed behavior. But we're trying to get this mental, like just changing the approach to things and making sure that, look, and to top it off, the price was exorbitant. From a few cents of an item, it went to like $5, $10 for just a needle syringe. And this is one of some of the findings from the study itself. So these are things that are changing, we're working on, and we've got the commissioner on board with us. We've got the Ministry of, I believe there's a Ministry of Police right now as well, that they've, Home Affairs that they've got now. So we're working with them and building it up. But honestly, like, if you've got the technical expertise, please drop me an email. I can connect the team to the people on the ground. I can leave my email out with Mark and team, and just drop me an email, and I can make the dots, connect the dots, and like literally link it. Like I said, I mean, a peer talking to a peer is more impactful over someone else. So I think, like I said, there's an opportunity there. I think my time is really up.